Can we have a mic for the speakers? We'll start the discussion, and luckily we have a good amount of time for discussion. We had listened and seen 8 interesting talks. I would like to involve the local panelists to see how can we integrate this in our local community and regional area, since we have a different pathology and different techniques and lack of iBanking and challenges. I'll start with Mohammed. First of all, for the local speaker, what's the percentage, all the local speaker, what's the percentage of BKs nowadays in your practice? What are the AKs challenges you are facing? So let's start with Mohammed. What is the percent, and what is the challenges you are facing with endothelial keratoplasty or lamellar keratoplasty in our region? Can you open this mic, please?
No?
Yes.
Yes, okay. So if you look at KKESH statistics, the #1 surgery is DALK for keratoconus. And it is followed by a complicated pseudophakic bullous keratopathy for DASEC, the second. PK is not much anymore in our statistics as
Very
before. It's usually reserved for an advanced complicated pseudophakic bullous keratopathy and infections.
And what about the endothelial keratoplasty? You said bullous keratopathy, right?
Yeah. So we don't face folks as much, and therefore we face a delayed presentation of complicated cataract and pseudophakic bullous keratopathy. Therefore, you'll find surgeons leaning toward DASEC. They have one chance, and they rely on imported tissue. They don't want to mess it up. Usually, the eye has already a difficult view, glaucoma, synechiae, and so on and so forth. Yeah.
Perfect.
Yeah.
Since you are also the chair of the iBank and you imported a very important topic, which is importing the cornea. We still rely on important cornea from the US in here. I understand there is also a pre-cut DSEC and preloaded DMEX. We import these as well. There is a huge transportation time. Did you have any challenges with these?
Yes, we did. So also in KKESH, if you look at our practice, we tend to do DASECs as surgeon cut, but in 2019 we shifted toward pre-cuts, and we started to notice a higher number of primary graft failure. And when we analyzed this group, we noticed that the group that had this failure was the group that had a delayed surgery from the processing time, probably day 5, day 6 from processing. They had primary graft failure.
Perfect.
So the bottom line, primary graft pre-cut does not work as well when we get it imported. Yeah.
Luckily,
Do you have any point about that, Dr. Hanush?
Well, when we looked at the results of the CDS, the cornea donor study, we showed that tissue up to 10 or 11 days does just as well as tissue that has been transplanted within the first 3 days. Now, all of us want the freshest tissue possible. I'm not sure whether the delay in transplantation is the only reason for... Yeah, so from the processing to the transplantation, there may be other factors involved. So we ship in the United States, we are fortunate to have about 100,000 pieces available for transplantation. We use about 48,000 and export the rest. The majority of them are doing well. Maybe you're referring specifically to the tissue prepared for endothelial keratoplasty, and for that tissue, the jury is still out on that. We need to figure out why these problems are there.
I agree with you, with Mohammed. I'll give you. I order also pre-cut DSEC, and when I transplanted during the surgery, I could see that the tissue is very thick and swollen. Even with intraoperative OCT, it's almost equal to the full corneal thickness. And luckily, I didn't have any primary failures, but I could see why it's happening.
No, but one other observation that DMEC, we had no problems with DMEC, even if it was delayed processing, even if it was day 6. So DMEC was successful if the surgery went well. Yeah.
Yeah.
So in that case, why import pre-cut DSEC tissue? If the issue is the availability of tissue, you can cut it yourself, no?
This is another extra cost of cutting a DSEK tissue, or getting a machine for maybe a big place like Kekesh, and they've been doing that, might not be a bad idea. I probably prefer to do more DMEX nowadays. I still import pre-cut DSEKs for complex situation. Luckily, I didn't have any primary failure, but this is a challenge we are facing in the region.
And that's what we do in Kekesh. We shifted back to a surgeon cut, but in private practice, some would like to have a pre-cut. They don't have the instrumentation.
No, that was all great talk. Thank you very much. So in terms of the DSEK, that was a very, very great topic actually, because we are getting increasingly pre-cut and pre-stripped, for example, DSEK or pre-stripped DMEG. And what our experience actually, when I was in Liverpool, we did receive pre-cut DSEK from various eye banks. And actually, it depends from which bank you get it. You get a huge variation in terms of the thickness, but also the attachment and the bubbling rate. We noticed from one specific bank we get it. Actually, the result for DSEK, for those complex cases, were almost as good as the DMEG. They clear very quickly. So I think the processing, the bank that you get it, has a huge role. But in terms of the DMEG, my personal experience being I have used pre-stripped and pre-loaded DMEG, and noted certainly in my hands I had much higher rebubbling rate for those preloaded and pre-processed DMEG. Luckily I didn't have any failure, but I needed to do more rebubbling of those cases. But another important factor is for the preloaded, pre-stained DMEG. I noticed that by the time they got to us, actually the stain, although they've got a bit of vision blue, but the view will be very, very poor. So I personally, even if I get a pre-stripped one, I tend to stain it on the day just before insertion, because when we're doing DMEG, and I personally feel one of the main challenges why people, or DMEG is not adapted as widely as it is because of poor visualization. Because if you don't have a good visualization, unfolding and getting that into right configuration is incredibly challenging. And I think staining your DMEG yourself is very, very important. And another important factor is if you're just starting DMEG surgery, is using, for example, something like membrane blue rather than vision blue for staining. And in my personal experience, when I changed and shifted to membrane blue, I almost, exactly like Murad said, I only use this DSEK for very complex cases, aphakic patients, where we feel folding will be very, very challenging.
Thank you. Is there any question from Professor Daya?
I have a question for Sadir. Sadir, the United States is very unenthusiastic about doing lamellar grafts. Out of those 500, I expect you probably accounted for 20% of them, right? Sorry, that's a cheeky question. My question really is, why are they unenthusiastic about doing grafts, lamellar grafts in the United States?
Well, I have a lot to say about that, Shiraz, and you and I have shared this over the years. It remains a little bit of a mystery, but I can tell you this. Of the 1,800 or so fellowship-trained cornea specialists in the U.S., only 1 out of 7 is doing a reasonable number of grafts, right? So most fellowship-trained cornea people are not doing a lot of grafts. And in their hands, they find lamellar keratoplasty more challenging. That's the main issue. And therefore, it's always easy, if you have access to good donor tissue, to do a full-thickness graft. Moreover, what we teach in our courses is that don't hesitate to try a lamellar graft, because if you fail, you can always do a full-thickness graft. You have the tissue, and before you strip the Descemet's membrane off the donor, if you fail with the recipient, you can always do a full-thickness graft. But the truth is, people are giving up too early and converting to a PK. And the last thing, which I'm embarrassed to admit to, but it's the truth, in the US, most insurance programs pay less for a deep anterior lamellar keratoplasty than they do for a full-thickness graft. So it's a very poor incentive for someone to do what they, in their hands, consider a more difficult procedure, especially when most of these patients are being done as outpatients in surgery centers, and the nurse administrator is breathing down your neck to get out of there so that their staff can go home. So these are the factors that affect real life. I don't think this is going to grow very much in the future unless there's a philosophical change.
Thank you, Sadir, and thanks everyone. Thanks for the panelists and the speakers. I have to stop in here and start the opening ceremony. Thank you, everyone. Please remain seated for the opening ceremony. Thank you.